Hello everyone, and welcome to our session on venous leg ulcers. I am Hans-Pieter Snels, representing DEBx Medical, and I'm the Clinical and Product Director. Today we have 40 to 45 minutes together, and my goal is to provide you with a comprehensive overview of wound healing and practical guidance you can take straight into your clinical practice. To start, we will look at how the body normally heals skin after an injury, what steps this follows, and why sometimes those steps go off track. We'll then explore biofilm, what they are, and how they form in wounds, and why they matter in chronic wounds. We'll also introduce the time framework and clear roadmap for managing chronic wounds. Time stands for tissue management, infection control, moisture balance, and edge advancement. After a quick review of the main topics of chronic wounds you see in practice, we'll dive deeper into venous leg ulcers. We look into why they develop, what you'll observe in clinic, and standard approaches you might already use. Approaches like compression therapy and various debridement methods. We'll then examine real case studies and show how adding chemical debridement can transform patient outcomes, highlighting both traditional and advanced approaches. And that leads us to DEBRICHEM, DEBx Medical single-use gel for selective chemical debridement. We'll cover what it is, what it works on in molecular level, and practical steps for safe and effective application. We'll finish with tips on managing patient comfort, ensuring some pain control, and then open the floor for some questions from you. By the end of this webinar, you'll both have the conceptual understanding of concrete steps to optimize care for your patients in venous leg ulcers. So let's get started. We're going to talk about general wound healing. When a skin is injured, whether by a cut, a scrape, or other trauma, the body treats it like a construction project. So, a breach of the skin is what we call a wound. 4 distinct phases take place in sequence, each one partly overlapping and dependent on the prior. The first phase is hemostasis. The moment skin is breached, vessels are damaged, and platelets rush in to form a clot. Imagine placing a temporary plug on a leaking pipe, for example, to stop the flow. Platelets release factors and molecules that constrict vessels and create a fibrin mesh, and that mesh is a scaffolding for the next screws to arrive. So in that second phase, the inflammation phase, within minutes and hours after the damage, neutrophils and macrophages arrive at the wound bed. These cells clear bacteria and debris. And think of sanitation workers removing the rubble before rebuilding can begin. They release signaling molecules called cytokines and growth factors that recruit and regulate other cells. The macrophages then transition from a destructive role into a repair-promoting role, setting the stage for new tissue formation. Phase 3, the proliferation phase. Over several days, fibroblasts migrate onto the wound, synthesizing collagen and extracellular matrix, the building bricks for this new tissue. Endothelial cells sprout to form new blood vessels, a process called angiogenesis, which restores oxygen and nutrient inflow. And then we have the keratinocytes, and they move across the wound surface, re-establishing the epidermal barrier. If you compare it to a construction site, carpenters, plumbers, and electricians all together working to rebuild the walls, wiring, and plumbing, so a structure can be functioning again. Finally, the remodeling phase, which can last up to weeks, even to months, and even sometimes a year. And collagen has been laid down in the proliferative phase as a structure for the reorganization along the lines of the tensile strength. Excess blood vessels regress, and cellular activity slows. The wound contracts and gains tensile strength, though often at about 80% of the original skin strength. This phase ensures the durable and final scar. For most acute wounds, these phases proceed smoothly, resulting in closure and functional recovery. However, any hiccup in this process can stall this progress. If hemostasis is incomplete, ongoing bleeding can impair clot formation. If inflammation persists due to devitalized tissue, infection, foreign bodies, or biofilm, the healing signals get disrupted. Insufficient angiogenesis starves the wounds even from oxygen. Excessive matrix deposition can lead to fibrosis rather than healthy tissue. When a wound remains in any phase for more than 4 weeks, it's considered to be chronic. Chronic wounds are not simply slow to heal. They can be stuck in a state of low-grade inflammation, high protease activity, and/or impaired cell migration in chronic wounds. In these chronic wounds, levels of inflammatory cytokines remain elevated and growth factor signaling is dysregulated. So this hostile microenvironment demands targeted interventions, removing the hostile tissue, controlling the microbial burden, balancing moisture, and support healthy tissue growth. Understanding the cascade of normal wound healing allows us to pinpoint where interventions can then be most effective. Debridement, for example, clears the field of infection and controls the removal of barriers, and moisture balance provides the environment for cell activity, and supporting wound edges enables reepithelialization. With this foundation in place, we can address the challenges of chronic wounds. One of those major challenges in chronic wounds is biofilm. In a wound bed environment, bacteria are often not lone swimmers. They form biofilms. Biofilms are structured bacterial communities encased in self-produced extracellular matrix. If you picture bacteria as settlers, biofilm is their fortified city walls, so to speak. This matrix comprises of polysaccharides, proteins, and extracellular DNA. It anchors the bacterial community to the wound bed and protects them from external threats. Biofilms develop in stages. The initial stage of adhesion of a planktonic bacteria, a free-floating bacteria, to a surface. Then the colony formation starts, and then the production of a protective matrix comes in, moving into maturation into a complex three-dimensional structure. Mature biofilms can host multiple species. Biofilms can create gradients of oxygen and nutrients that support both aerobic and anaerobic organisms. This heterogeneity contributes to resilience of the bacteria and biofilm. Some cells enter a slow-growing persister state that resists antibiotic targeting and bacteria with active metabolism. Clinically, biofilm-laden wounds can appear deceptively clean on the surface. It can have slough and that clings rather than lifts. Persistent exudate and cyclical flare-ups of infection can be present. Standard swab cultures, for example, of the wound bed could potentially underdiagnose these biofilms because they sample the surface organisms rather than those within the matrix of the biofilm. If a wound is stalled healing for more than 2 weeks, despite optimal care, biofilm is likely the culprit. Why do biofilms resist this conventional therapy? Well, first, the matrix acts as a diffusion barrier, reducing penetration of antimicrobials up to 10 to 1,000-fold even. Second, bacteria within biofilms express different genes, upregulating, for example, stress response proteins that expel or neutralize drugs. Thirdly, the matrix can bind antimicrobials, isolating them to even reach the bacterial cells. Biofilms also impair the host immune response, so neutrophils and macrophages release enzymes and reactive oxygen species that can damage the healthy tissue while they are intended and aimed for the bacteria inside the matrix. Persistent inflammatory signaling leads to chronic protease activity, which degrades these growth factors and extracellular matrix formation for wound healing. Therefore, it further prevents the progression of proliferative and remodeling phases of the wound healing. Breaking down biofilm requires targeted strategies. So we have mechanical debridement, physically removes the matrix, exposing bacteria to the immune cells and topical agents. Enzymatic debridement uses enzymes like DNases or proteases to cleave matrix components. And then chemical debridement, such as acidic gels, denatures matrix proteins and disrupt bacterial cells' walls. Each method has their pros and cons, and mechanical can be painful. Enzymatic can be quite slow or even costly due to the time. And chemical requires careful neutralization. Often, a combination of those yields the best results. Active biofilm management is important to transition a chronic wound back into the healing trajectory. So once the matrix is disrupted and antimicrobials can reach bacteria, inflammation subsides, and the wound bed becomes receptive to proliferation and remodeling signals. And this sets the stage for applying that time framework. So treating a chronic wound using the time framework, it provides a systemic approach to chronic wound management, ensuring no critical element is overlooked. So time stands for tissue management, infection control, moisture balance, and edge advancement. The T stands for tissue management and involves removing the devitalized tissue, slough, and foreign material. This can be achieved via several methods, for example, mechanical debridement, such as low pressure irrigation or fluid share, wet to dry dressing, using friction. It is fast and familiar, but can traumatize the healthy tissue as well and be painful for the patient. So autolytic debridement is an option, uses occlusive, semi-occlusive dressings to harness endogenous enzymes, and wounds' own moisture softens the necrotic tissue, which is then removed painlessly at every dressing change. But the process can take some weeks. And then you have enzymatic debridement, which applies proteolytic agents like collagenases. These agents selectively digest the necrotic collagen and accelerating the removal compared to autolytic debridement. But repeated application and cost can be still a limiting factor here. Then you have sharp debridement with a scalpel or a curette, and is the gold standard for rapid tissue removal. It requires skill to avoid this healthy tissue in the sharp debridement, and there is a risk of pain and some bleeding. Sharp debridement can clear extensive necrosis in a single session, making it highly efficient in experienced hands. Then the I in time stands for infection control and focuses on reducing the microbial burden. Culture-guided systemic antibiotics address deep and or spreading infections, where topical antiseptics such as polyhexanides or silver-impregnated dressings help to control the surface bioburden. Debridement itself reduces the niche for the bacteria. The combination of methods often yields the best outcomes here as well. The M in time stands for moisture balance, and it's about creating an optimal environment for cell activity. Dressings range from highly absorbent foams to exudative wounds to hydrogels and hydrocolloids for dry wounds. Too much exudate leads to maceration of the peri-wound skin, while continuous desiccation slows the cell migration. The right dressing maintains a moist interface that promotes that autolytic debridement and cell proliferation. Then the E in time stands for edge advancement, and this means actually ensuring the wound margins are active and advancing. Peri-wound callus and hyperkeratosis can physically block these epithelial cells from migrating from the edge into the wound. And techniques like surgical edge debridement and topical growth factor applications can stimulate the keratinocytes' migration. Supportive measures such as offloading pressure of diabetic foot ulcers and optimizing nutrition also help edge advancement and to close that wound gap. Integrating the time framework requires regular reassessment. It's important that at each dressing change, the wound is evaluated on the tissue quality, microbial load, exudate levels, the edge status, and interventions are then adjusted accordingly. For example, switch from autolytic to enzymatic debridement if slough persists, or add an antimicrobial dressing if bioburden increases. Time is a dynamic framework, not a one-time checklist. So by addressing all four domains in concert, and you can create a wound environment that is primed for progression. And progression through the proliferation and remodeling phases, moving the chronic wound back into the healing trajectory. In clinical practice, we see different types of wounds. We categorize chronic wounds into 5 major types: diabetic foot ulcers, pressure ulcers, arterial ulcers, post-trauma ulcers, and venous leg ulcers, each of which their unique pathophysiology and management priorities. Diabetic foot ulcers, for example, they occur when neuropathy and peripheral arterial diseases are present, where loss of sensation leads to repeated microtrauma, poor blood flow impairs the healing, so offloading pressure and optimizing glycemic control and treating the infection are key to resolve diabetic foot ulcers. In pressure ulcers, also called bed sores, form over these bony prominences under sustained pressure. So preventing through frequent repositioning and using pressure redistribution services is essential. This, in combination with the standard wound care, is needed where ulcers then develop. Arterial ulcers, they result from critical limb ischemia. They appear punched out with minimal exudate and have often a painful, pale base. And revascularization is vital, combined with local wound management. Then we have the post-trauma ulcers, and they may arise at surgical sites or from trauma or repetitive friction or shear. Addressing underlying issues or additional surgical techniques, plus standard wound care promotes this resolution of these ulcers. And then we have venous leg ulcers. They're the most prevalent. Up to 70% of lower limb wounds have a venous insufficiency component. They stem from venous hypertension due to the valve failure, leading to fluid leakage, inflammation, and tissue breakdown, particularly in the area above the ankle and up to the knee. Understanding wound types guides first-line strategies. Think offloading for diabetic foot ulcers, revascularization for the arterial or pressure relief for the pressure ulcers. But today we focus on venous leg ulcers because of their high prevalence and distinct treatment path, including compression and specialized debridement. So, the main subject of this webinar, the venous leg ulcers. Venous leg ulcers develop when one-way valves in the legs, in the deep and the superficial veins, fail to maintain the returning blood flow. Veins have these valves to prevent the reflux of the blood into the venous system. Normally, muscle contraction squeezes the veins and pushing the blood towards the heart. When then venous valves are incompetent, the blood pools. In the lower leg, this and gravity elevates this hydrostatic pressure. The hydrostatic pressure then has fluid and proteins that leak into the interstitial tissues, causing chronic edema. And over time, the stretched skin and the high pressure causes microvascular damage, leading to tissue breakdown and then ulceration. Critically, you'll note several signs. The location is an area between the knee and the ankle and often just above the medial malleolus. Appearance of the ulcer is an irregular shape, shallow wound with granulating red base or sloughy areas, and the edges are uneven, and the wound size can vary wildly. Exudate levels are moderate to high due to the increased capillary filtration and the edema, and the peri-wound changes into a brown-like skin staining, and lipodermatosclerosis can cause a firm, woody texture. Eczema and pruritus often accompany these changes as well. So the first line strategy is correction of that venous hypertension. And this can be done via the compression therapy. This is a cornerstone. Graduated elastic compression stockings apply higher pressure at the ankle for 30 to 40 millimeters mercury, tapering towards the calf muscle. Multi-layer bandaging systems can achieve higher sustained pressures. Compression narrows veins and supports the valve coaptation and improves the venous return. So this will reduce the edema and inflammatory mediators. Patient education here is crucial because it is important to instruct the patient on correct compression stocking use, skin care to prevent dermatitis, and the importance of ankle exercises to pump the blood. However, compression alone is not enough to remove the established devitalized tissue, infection, slough, or biofilm, so it's imperative to pair it with wound bed preparation via the time principle. So let's discuss with two cases where we manage time with chemical debridement and compression. So the first case is a 7-month-old diabetic venous ulcer managed with DEBRICHEM and negative pressure wound therapy. A 75-year-old woman with diabetes and hypertension presents with a lower left leg wound. This wound had persisted for 7 months. The lesion began as a small trauma but progressed despite advanced dressings and home-based antibiotic therapy. Wound cultures revealed Pseudomonas aeruginosa. Echo Doppler ruled out arterial disease. A single application of DEBRICHEM, or chemical debridement, produced immediate carbonization of devitalized tissue, and negative pressure wound therapy was initiated straight after the 60-second rinse and maintained for 3 days. Exudation stopped within the first 24 hours, and by day 3 the wound bed showed remarkably reduced carbonization and early granulation. And by day 6, full granulation was visible. So the NPWT was discontinued, and the patient has been scheduled for a split thickness skin graft on day 8. The next case is a 80-year-old woman with a decade-long bilateral venous leg ulcer on both her legs. Her medical background reads like a long checklist: renal failure, coronary artery disease, hyperthyroidism, diabetes, history of erysipelas, anemia, you name it. Every one of those conditions can slow healing. Prior to DEBRICHEM, the team used antimicrobial and absorbative dressings. Yet, compression therapy was impossible because the wounds were simply too painful. In this first figure, it shows the starting point. Widespread slough, high level of exudate, and the tenderness that limited even gentle bandaging. We applied a single layer of DEBRICHEM on each ulcer. Within 2 weeks, both wound beds were fully granulated. And as you can see in this second picture, the surprise benefit was the pain relief. The patient reported such a drop in discomfort that we could finally introduce a layered compression, and a key element for the venous return. From that point, we kept things simple: antimicrobial dressings plus compression. The tissue continued to remodel without additional debridement, and 9 weeks after the first application with DEBRICHEM, the ulcer had completely epithelialized, giving us a smooth, intact skin, as you can see in this last picture. So, key points to remember here are: pain reduction after chemical debridement opened the door to compression, which had been off the table for quite some time, years even. And a single DEBRICHEM session was enough to restart healing in ulcers that had been static for a decade. Even in complex multimorbid patients, you can achieve closure in a matter of weeks when the wound bed is swiftly converted into a healthy granulative state. These cases highlight now chemical debridement with DEBRICHEM, and it can streamline care, reduce pain, and accelerate healing when combined with standard venous correction. But what is chemical debridement with DEBRICHEM, and how does it work? Well, DEBRICHEM is a CE-marked Class 2B medical device designed for chemical debridement of chronic wounds. It comes as a single-use acidic gel applied directly onto the wound bed, and within 60 seconds, it removes the devitalized tissue, biofilm, and infection, creating a clean and stable wound bed. After 60 seconds, you rinse it off with saline, and you apply a dressing as usual. And whether the treatment plan continues with advanced therapies like NPWT or just standard dressings, DEBRICHEM helps to restart the healing process. It's suitable for outpatient use in community settings. At no surgery, no bleeding, and minimal resources are required. Let's have a look at this animated video explaining the mode of action of DEBRICHEM. In this animated video, we're talking about a wound model where we see a biofilm development from planktonic bacteria. So the planktonic bacteria, they form this biofilm that matures into 12 hours, which is a very brief period, and then you get that very mature biofilm. which causes that protective layer that these bacteria can sit in. So in this frame, you see that the bacteria are multiplying, that the biofilm forms on a wound bed. And from there, we can see that this biofilm has a lot of water content. Up to 97% in the biofilm is water. The rest is some polysaccharides, proteins, and glycoproteins that form the extracellular matrix. And that's where DEBRICHEM comes in handy, because it eliminates the biofilm by disrupting in just a matter of seconds with one application. And this is because it binds with water molecules. So the acidic principle in DEBRICHEM binds with the water molecules, releasing a lot of energy, dehydrating the wound bed. So with this energy release, we can see that there is a big desiccating effect in the wound bed. So DEBRICHEM's application you just saw, where it goes over the wound and the peri-wound, and here you can see it penetrating into the biofilm, capturing the water molecules by DEBRICHEM molecules. This is an energy release that breaks down even bonds and disrupt the biofilm, disrupt this extracellular matrix that we were discussing. Eventually, this will lead to that microbial death of these bacteria. So by keeping all these water molecules away from the bacteria, they come into a hyperosmotic state, and where they react with the energy release, and there the bonds are broken down of those membranes. So bacteria break down, the biofilm breaks down, and eventually there is just some dehydrated material left. As this is such a aspecific way of treating the biofilm, there's also no known bacterial resistance, and this dehydration is accompanied with a bit of a color change after the wound bed is prepared with DEBRICHEM. Now that we have seen the mode of action in detail, you're probably wondering, how does it work in the clinical practice? And so let's have a look in another video of the instructions of use. In this video, we look at the application process of DEBRICHEM. We have a venous leg ulcer here, as we are discussing in this webinar. And here we see the tissue viability nurse preparing the working area for the treatment. So this is what you go about as you would normally do. You prepare the working area with the materials you need. You prepare the area where the patient can take place. You make sure that you take the materials out that are for wound cleansing, but also for your personal protection. So you have your gloves ready and your other materials. Maybe you can wear some glasses if you want. And then you would go to the patient, make sure they are comfortable on their treatment table, and you remove the dressing. And when the dressing is removed, you also inspect, of course, how the wound looks like and how it's going. Then you clean it. So you take a bit of saline and some gauzes to cleanse the wound. This is all regular wound care process. Then from there, we take on for this patient, because there is a bit sensation in the wound bed, also some anesthetic. And here we use an EMLA cream for 5%, and we left that on for 20 minutes. And after that, the wound bed site was sufficiently numbed to go about with proper cleansing and the debridement with DEBRICHEM. So here you see the removal of the EMLA cream, and then you can take on DEBRICHEM. After shaking the bottle, you pour it out of the bottle all the way onto the wound bed, but also covering the peri-wound, which is also very well displayed here. And from there, the timer has started already for the 60 seconds. It's been speed up for this frame. And after the 60 seconds, you come in with the saline or sterile water to rinse off and neutralize the effect, because DEBRICHEM reacts with water, so it's also neutralized in plenty of water. And you can see that it's a very easy way to use the product, and also see that the wound bed really changes after the treatment. So you can see after drying the wound bed that from there you can prepare the wound for the rest of the dressing and make sure that it's covered, and you use the dressing as you would normally do for this type of wound. Then you clean up the rest, make the bandage ready, and for this case, a compression bandage as it's a venous leg ulcer, and then the patient can be sent home. All right, so to summarize here, some practical key points. Fast and focused. DEBRICHEM is a single-use gel applied for just 60 seconds to remove devitalized tissue, biofilm, and infection. It's a smart mode of action. It works by withdrawing water from the devitalized tissue and the biofilm, causing a structural collapse and neutralization of the microbial load without harming healthy skin. It's easy to use, no surgical instruments or theater time required. DEBRICHEM fits seamlessly into the inpatient, outpatient, and even bedside care workflows. It's an advanced wound bed preparation. It prepares the wound bed for healing, either as a standalone intervention or before the use of advanced therapies like NPWT or even grafting. So let's talk about some practical tips for application and pain management for optimal results and patient comfort. And you should follow these steps. So in the preparation, ensure the wound bed is free of dressings, debris, and other topical ointments. Clean with saline, pat the wound bed dry with any gauze, and then apply a topical anesthetic. A 5% lidocaine or EMLA cream for 30 to 60 minutes, covering the entire wound and at least 1 centimeter margin of healthy skin. Then, for the application, shake the DEBRICHEM vial for 30 seconds to reduce the viscosity. Apply the full volume of the gel evenly across the wound bed and the peri-wound skin. Massage gently for 10 seconds to ensure even coverage and distribution. And then start a 60-second timer at the first drop contacting the tissue. In the aftercare, rinse thoroughly with sterile saline or sterile water to neutralize DEBRICHEM's action. Gently pat the area dry, leaving the carbonized necrotic tissue in place to slough off over days. Choose a dressing that balances moisture. For example, use foam dressing for high exudative wounds, hydrocolloids for moderate exudate, and advise the patient that the darkened and changed appearance is expected, an expected carbonization, and not new necrosis. Provide some oral painkiller if needed, or additional topical anesthesia for major discomfort, but most pain resolves within 10 to 15 minutes. Common concerns that we come across are that patients may worry about that blackened material, that it's harmful. So just reassure them it is part of the process and it will detach naturally. Avoid forceful removal of adherent material to prevent bleeding, and monitor for peri-wound maceration, so change the dressings is needed to maintain a stable moisture balance. And now we're also almost coming to an end of this webinar. So let's address a couple of questions you frequently encounter. Is the pain management? Patients feel a stinging or a burning sensation during the 60 seconds exposure. Topical anesthetics or painkillers keep the patients comfortable. And document the pre and post procedure pain scores to track the trends there. A need for repeated application. In most cases, one session of DEBRICHEM, one application is enough. So reapply only if there is evidence of new infection somewhere down the line at the follow-up. Contraindications: do not use any DEBRICHEM when any contraindication is present. We recommend always to consult the instruction for use before applying DEBRICHEM. Additional resources, another topic. Well, DEBx Medical Academy offers online modules on patient selection, cost-benefit analysis tools, and step-by-step application videos. So we also provide patient education in brochures and wound care documentation templates. And if you have any questions, please reach out to us in case you're interested in receiving access to these materials. We have come to the end of this webinar. Today we reviewed normal wound healing phases, biofilm impact, and the time framework. We saw how venous leg ulcers develop and why compression is important, but also combined with targeted debridement that accelerate healing. Through case studies, we observed the benefit of this integrating with chemical debridement into the practice. We explored DEBRICHEM in depth, its mechanism, the safe use, and the compatibility. Finally, we covered practical tips for application and pain management. So thank you very much for paying attention. If you'd like a live demonstration and see the results on your own patients, we are happy to come by and treat 3 to 5 patients at your facility. You can schedule a live demonstration via our website, and a link will be provided in the description of this webinar. Have a great day and happy wound healing.